If you wouldn't mind muting yourselves if you're not speaking, that would be great. We have a large group on today and we have a full agenda. So we're excited to get started here as folks join from the waiting room. Thanks again for muting yourself if you're not speaking, and please do use the chat if you have questions for us. We would love to have an interactive conversation, as interactive as it can be, with a number of people on the call today. So we'll start as we typically do with a brief introduction of our group, with our speakers. And we're going to hear a state level update from California, Michelle Canales from the Office of Senator Ana Caballero. We'll hear from Joseph Simonetti out of the VHA, sharing his example of cost of effectiveness, his recent publication. We're excited to hear. And we also have Dr. Scott Brunner out of Monarch Healthcare in Southern California, sharing an example of their e-consult program. And we'll spend a few minutes on announcements and Q&A, and we look forward to hearing from you all. So please take a moment if you want to ask questions, if you want to use your chat feature to introduce yourself. If you're new to the work group, please do that. We, as the e-consult work group, have been around for about 6 years now. We appreciate California Healthcare Foundation and other sponsors keeping our work going and offering what is not just a California, it started out as sort of a California focused group. Now we are not only a national group, but we are international. So we're happy always to see faces from Canada. Today we have a representative from West Africa, so we're just so excited that our group has grown to become international. Without further ado, I'm going to hand off to our first speaker, and I think you're on, Michelle Canales. Michelle, are you on with us? Great. Go ahead, Michelle, providing a quick update.
Hi there, thank you, Libby. So SB 365, just in case you haven't had a look at it yet, this bill allows for reimbursement of e-consults under Medi-Cal for primary care providers and really anybody initiating the e-consult from the originating site. So the bill has passed Health Committee. It is in Senate Appropriations. It will be heard May 3rd at 9 a.m. Because of the cost of the bill, it will go straight to the suspense file. And that means that the senator does not give a presentation on it. The suspense file is then taken up by May 21st. So that's when every bill that's on the suspense file basically gets decided whether or not it's going to move forward or be held in the Appropriations Committee. So at this time, the sponsors and I have had really great conversations with the consultant in the Senate Appropriations Committee who is analyzing the bill, and we are looking for ways to help lower cost, which is a really big help to getting us out. That's where we are now, and if there are any questions, I can go ahead and leave my email in the chat.
Thanks so much, Michelle. If there's any interest in the history of where we got, how we got here over the past few years in terms of looking at State Bill 365, please do share. We're happy to correspond with you, since I know we have a good number of representatives from other states on the phone too. Thanks, Michelle, for your time. Appreciate it.
Absolutely.
I think we have Dr. Simonetti on the phone, and Dr. Simonetti, I'll let you unmute yourself and display your video if you can. We were so pleased to see a couple of months ago, I think it was January, we were pleased to see this publication come out. Just doing a quick mute of those who've just joined. Thank you so much for muting yourself if you are not speaking. We're pleased to see this study come out of the VHA, and Dr. Simonetti and his team sharing their examples of cost savings. I think over observing many programs of e-consult over the years, we look at efficiency so often. We see so many great examples of programs that are improving access to care. One piece that we're always interested in seeing is how we can measure cost savings. So I think this is going to be great to hear from Dr. Simonetti, how they were able to do this out of the VHA. The link to this study is in your PowerPoint deck, and it's also in our newsletter in case you'd like to read in more detail. So Dr. Simonetti, if you wouldn't mind introducing yourself, and I'll let you take it away, and I'll click for you. So go ahead.
That's great. Thanks, everybody. My name is Joe Simonetti. I'm a hospital medicine physician and a researcher in the VA Eastern Colorado system. I do my health services research with the Denver Seattle Center of Innovation for Veteran-Centered and Value-Driven Care, and the VA Collaborative Evaluation Center. This is some work that we started a few years ago to evaluate both some of the experience and perspectives of providers delivering e-consults within the VA healthcare system, and sort of a preliminary look in our perspective on some of the cost savings that could potentially be associated with e-consult delivery. Next slide. I'm presenting on behalf of quite a large team. Melanie Whittington is actually the PI, the first author and the economist who actually conducted the work that I'll be presenting today. She's really the core methodologist for this work, and unfortunately she couldn't be here. Michael Ho is one of the senior investigators within VA who has also helped me lead this work. Next slide. So just a little bit of background in VA. E-consults were piloted first around 2011 in a small sample of VA facilities with the goal that you see everywhere to improve access to specialty care. Since then, the program has rapidly expanded. Since that time, there's been millions of e-consults delivered in the Veterans Health Administration. Right now, if you look at all specialty consults that are conducted on an annual basis, the American Journal of Managed Care, and David Saxon, one of my colleagues, just published this within the last month, found that about 5.5% of all specialty consults that take place in VA right now are done through an e-consult mechanism. And some of the specialties are actually now over 10%. There's been more than a 300% increase in VA consult use in the past 7 years in VA. Despite that, what you can see here in this lower graph is variation by VISN. A VISN is basically a regional designation for VA care. And across the different regions of care that we deliver in the VA, there's been really substantial variation in the uptake and use of e-consult mechanisms. Next slide. The same holds true, I think many of you have probably already witnessed this within specialties themselves. So what you see here in the dark blue columns is basically the number of consults that are occurring annually within VA, and the light blue bar is the percentage of all of those consults that are done through an e-consult mechanism. And so, for instance, you might see in hematology, nearly 20% of all medical specialty consults are actually done through an e-consult mechanism. So a lot of variation by specialty. Next slide. I'm going to present sort of a slice of overall work today, but the aim of the project in general was first to do a broad qualitative exploration of the perspectives of both providers and some stakeholders in terms of challenges and facilitators and personal opinions about using e-consults within their clinical practice. I'm not really going to focus on that work today. What I'm going to talk about today is our work looking at an economic evaluation comparing individuals who received VA specialty consults through an e-consult mechanism versus a face-to-face consult. The primary outcome was total costs, and I'll present some that's stratified by both inpatient and outpatient costs. Next slide. So the methods for the economic analysis were fairly straightforward. So we looked at all veterans in calendar year 2016 who received either an e-consult or a face-to-face specialty consult to 11 total subspecialties in the VA. We broke them down into an intervention and a comparator cohort. The intervention cohort are simply a group of people who received an e-consult to that specialty. The comparator cohort was simply those who got the face-to-face consult and not the e-consult mechanism. We then matched them based on propensity scores in a 1-to-1 ratio, using patient characteristics such as age, race, and gender, Medicaid eligibility, which is a functional proxy for both the income of individuals and is also a proxy for whether or not they might have secondary insurance available, the medical specialty from which they received care, and patient comorbidities, which we know is significantly correlated with the cost. So that includes both their comorbidities, adjusting for their 1-year survival, and as sort of a baseline proxy for healthcare utilization and costs, we also adjusted and matched on their prior month total healthcare costs within the VA healthcare system. We used a regression model with a gamma distribution and a log link, basically because it's cost data and the data can be significantly skewed. After propensity matching, we also adjusted our models for very similar covariates, including individual characteristics, comorbidities, whether they resided in a rural or urban location, the distance they resided from the VA medical center in which they were getting care, and also the wage index and facility complexity. And so that basically has something to do with geographic variations in both healthcare utilization and cost. To further account for differences at facility levels, we clustered errors at the station ID. And then in the VA, as you might be aware, we now have a Mission Act. Initially, it was called the Choice Act, but this was an intention to begin expanding care for veterans getting VA services to get services outside of the VA healthcare system. And so beginning with the Choice Act, if you lived greater than 40 miles away, and there were a couple other factors that go into it, the VA would arrange or help facilitate you getting care from the private sector. And so as a sensitivity analysis, we decided to sort of take that out of the equation because we don't have those costs available to us and just look at individuals within a 40-mile perimeter of the VA medical center. Next slide. Just to give you an idea of the sample size we're talking about here, I don't want to go over these details, but we're talking about a lot of consults here. So in cardiology alone, we had 42,000 who received an e-consult, of 42,000 who got a face-to-face consult. On the lowest end of things, we had 8,000 individuals in the e-consult group and 8,000 individuals in the face-to-face group. So we're talking about a really big sample size here. Next slide. I did not present the full results, which you can find in the paper. These are basically our table 1 characteristics, taking a look at how the characteristics of the e-consult group differed from the face-to-face group after we matched them. I only presented a couple here because the story is pretty similar across all of 11 different subspecialties. And what you see here, and I'll just present cardiology as an example, the mean prior month outpatient costs, which is something we adjusted for, going into basically the analysis, were slightly higher in the e-consult group. And that held true, I think, for 8 or 9 of the 11 total specialties. So it was a costlier group going into the analysis. But when you look at their comorbidity, age, gender, whether they were married or not, Medicaid eligibility, race and ethnicity, there are very, very, very little differences between these two groups. And this is actually before we actually adjusted for them additionally in models. So a similar group. Next slide. This is, once again, this is reviewable in the paper, and we don't need to spend time going over each of the numbers in this slide. These are the average unadjusted total cost at 6 months between the groups. And so from the beginning of the analysis, we added up all costs in the two groups, and this is what they are at 6 months. And the point here is just to give you a baseline of the numbers that we're talking about. So for instance, in cardiology at 3 months and 6 months, the costs were right around $3,300 and $6,100 to $6,200. That's total cost in the e-consult and face-to-face group. On the low end of that in oncology, it was $700 in the e-consult group to $3,600 in the face-to-face cohort, $5,000 at 6 months, and $6,100 in the face-to-face cohort. So we're talking between $3,000 to $6,000 in total costs in 3 to 6 months. That we're using for comparisons here. Next slide. So this is, I presented basically the final results first, so you can kind of get to the punchline, and then we can talk a little bit of nuance here. These are the total costs at 3 and 6 months. This is the adjusted difference. So this is once you compare the e-consult group with the face-to-face group, accounting for all of the various confounders that I presented on my method slide. This is simply the percent difference. The baseline is the prior slide, the $3,000 to $6,000 or whatever it may be at 3 to 6 months. In cardiology, those who got an e-consult had 3.6% lower costs at 6 months. In diabetes care, those who got an e-consult had 22% lower costs at 3 months. Those in endocrinology had 9.5% fewer costs at 3 months. What you see here on the left side, which is 3 months total costs, across all 11 specialties, the adjusted differences show that the cost savings, the costs were lower among the e-consult group in comparison with the face-to-face group. When you take that out to 6 months, which is the right side of this table, costs were lower in the e-consult group for 10 of the 11 specialties. So cardiology became a null finding at 6 total months. What you also see here in this slide is we're talking about really, really substantial differences in costs. On the low end at 6 months, it appears that in endocrinology, those who got an e-consult as compared to a face-to-face visit had 10% lower costs. On the high end, looking at hematology, those who got an e-consult rather than a face-to-face visit had nearly 40% lower costs at 6 months. So big differences for some of these folks. Next slide, please. I don't present both. We looked at both outpatient and inpatient costs to get an idea of what really is driving these differences in outpatient costs. And what you see here are the adjusted differences in outpatient costs at 3 and 6 months. And this really is what drives the difference in total costs for 2 reasons. One, outpatient costs account for a majority of the costs at 3 and 6 months. Inpatient costs are a small percent of it, especially because few people are actually hospitalized in comparison to the total number of people who are getting outpatient care. And what you see really is the same thing here, that at 3 months, which is the left side of this table, there are statistically significant lower costs for the e-consult group in nearly everything except for cardiology. In cardiology, this is the one area in which costs appeared to be higher at 3 months, but at 6 months, the cardiology finding becomes null and costs are essentially lower in the e-consult group for outpatient settings for 10 of the 11 different specialties. So in summary, the costs were lower among basically all e-consult groups at 3 months and 10 of 11 at 6 months. This is a sort of a difficult estimate, but we estimate that approximately this saves about $110 million annually for the VA healthcare system. And those differences and those savings were largely driven by lower outpatient costs among the e-consult group in comparison with the face-to-face group. Next slide. There are some limitations to this, obviously. We propensity matched. We then additionally adjusted for what we felt were important confounders at the individual and facility level in our models, but this is not a randomized controlled trial. And so there is always possibility that there is residual confounding here. And one of the things that I find to be most concerning for these results is that we have really broadly lumped consults into big groups. So cardiology could be 20, 30 different reasons for consultation that we've all lumped under the umbrella of cardiology, for example. And we know that if you get a referral for heart failure, the cost for that might be different than if you're getting a referral for atrial fibrillation. So we simply can't account for that. And even though we adjusted for differences in comorbidities, that does not mean that individuals, say with lower complexity or lower costly e-consult reasons, weren't being filtered for an e-consult mechanism rather than a face-to-face visit. These are 3 to 6 month numbers, and so that is relatively short in the lifespan of a patient in a consult. And so an alternative explanation of these findings is that perhaps the e-consult just delayed inevitable care. And so by only looking at for 6 months, we just haven't really captured the full episode of care. We have to talk about the generalizability of this to other systems. VA facilities are given a bucket of money and they spend it how they spend it in a year. And that's how these costs are really worked at in the VA healthcare system. That's very different from how things are reimbursed in the private healthcare system. We really couldn't look at utilization, at least in this study, after the consult. And so again, at 6 month follow-up, we can't say what happens in terms of diagnostic imaging testing, how that differs between someone who's available to see a patient face-to-face and examine them versus somebody who has to do it through an e-consult mechanism. And the recent work by David Saxon, which just got published, showed that about 21% of all patients who get an e-consult mechanism will end up with a face-to-face visit within 12 months. It's unclear whether that's simply inevitable or that's just being delayed because the e-consult mechanism wasn't sufficient. And importantly, this is VA cost data. We know that people have dual insurance because of the choice and now the Mission Act, individuals can get care paid for outside of the VA healthcare system, and we don't have those cost data available to us. Again, as a sensitivity analysis that I mentioned, we looked at the individuals who were within 40 miles of the VA medical center, and that accounted for more than 98% of our sample. And so the differences really weren't that relevant, considering that the sensitivity analysis was nearly everybody who we had included in our main analysis. Next slide. I talked about one of my biggest concerns here is that there's a bunch of different reasons you can be sent to, and I'm just using cardiology as an example. And we really weren't able to identify whether or not the people who went to e-consults had sort of just lower cost consult questions than those who ended up in the face-to-face mechanism. And so this is some follow-up preliminary work that we did, which was just presented in November at the American Heart Association annual meeting. We did a small retrospective cohort study with a random national sample of VA patients. So we pulled roughly 300 patients across 43 medical centers nationally. And we went through the free text of cardiology consults to identify patients who were getting their first consult for either atrial fibrillation or atrial flutter. And so we pulled 176 individuals who got face-to-face consults and compared them using basically similar methods to 136 individuals who got e-consults for approximately the same reason. And in this analysis, what we found, the costs were approximately 41% higher among the e-consult group at 6 months. Challenging what we had found in our larger analysis when we start to poke away at that question of why people are actually being diverted to different mechanisms of consultation. The mean adjusted total costs at 6 months were nearly $13,000 in the e-consult group, and that's compared to $8,000 in the face-to-face group. So big differences there. Again, this is preliminary work that was presented in abstract form, but I think it begs the question of what happens when we start to actually think about e-consults and not just in the broader buckets of the specialty to which they're being referred. Next slide. I'm going to present just one slide on this. So I had mentioned earlier, as part of our broader work, we had done a large qualitative study of a national sample of providers to get their thoughts on how things were going with e-consult. What works, what doesn't work? Do you like them in your clinical practice? And we asked some primary care providers who were using them, some specialists who were responding to them, and then we looked at where there was overlap in those perspectives, or where could we find some agreement between these two groups. And for primary care providers, we noted that they felt that there's actually a lot of lack of awareness about e-consult availability. Not that they didn't know that it was a potential mechanism, but you could speak to a provider, say in Boise, and that provider would say, well, you know, it's interesting. I have a lot of patients who need dermatology care. I actually have no idea if there's an e-consult mechanism that I could use for that. One of the biggest findings we had in this group, which we just published in JAMA Network Open, is that the primary care doctors really felt that while these are great, they liked e-consults. They thought it was really important to have them. It provided high-level care, and it was really important for patient care, especially because it reduced the burden on patients and patient travel. They felt that a lot of work was being shifted on their plate that ultimately would not have been there had there not been an e-consult mechanism. So historically, if I want somebody to manage atrial fibrillation for me, I say consult cardiology. My patient goes to see somebody in cardiology, and atrial fibrillation management is basically taken care of to me until things are stable. If I alternatively have a question about why somebody has an anemia and I send an e-consult to a hematologist, the hematologist might respond with, please order all these labs. And then it's up to me as the PCP to order the labs, to get the results, to communicate them to the patient. In some cases, this means interpretation of tests that I haven't been trained to interpret. And so there's a lot that actually comes with that besides just sending off the e-consult mechanism. The specialists had some concerns about workload credit, basically how this is being accounted for in their workday, that the templates that are often used to harness e-consult information weren't necessarily all that efficient in every case and could probably be better. And there needs to be a triage mechanism, and that is if it can't just be a bucket of e-consults coming my way, they should be triaged to certain providers, and certain questions should actually be triaged away from e-consults. Both groups basically said that task responsibilities were a problem. We don't know who orders tests, who's supposed to interpret them, who's supposed to follow up on them. Though I think both groups felt that the care was actually quite good, but we don't actually know that. There has not been really high quality assessments of the quality of care delivered through e-consult mechanisms. There's not really a feedback process between specialists and providers to say, hey, this could have done better. How can we improve this in the future? And time and time again, folks stress the importance of just identifying the right patients. This is a patient who needs an e-consult because this is a question that can be answered, or it's a patient who is not going to travel to see you otherwise. And here are the patients who really just aren't going to benefit from this and probably should be seen face-to-face. There's really been no work done trying to help us as clinicians or policymakers understand, the latent classes of patients who might be well fit as people who should get e-consults. Next slide. As part of this work, we put together a toolkit which we can make available. And this is sort of just a summary of our quantitative and qualitative findings of the work as it relates to VA. It's a nuts and bolts primer for specialists and primary care docs in the VA to understand what it means to place and respond to e-consults. This is really for a group of providers who haven't been using it previously. And then some of our best practices suggestions for how you can sort of develop and facilitate a local e-consults program using stakeholder feedback from both sides of the equation. Next slide.
Can I pause really quickly, Dr. Simonetti? We've had a few people ask around how they might access this toolkit, if it's shareable. Is it something that you do share? Can you talk to that?
It is shareable. I have it on my to-do list to send to you, and then if you want to distribute it any way you'd like to, you're welcome to. And that's it I have. So thanks on behalf of the team. I can distribute that toolkit. You're welcome to follow up with me via email. There are some questions and comments here up in the chat, which I'm happy to go through. Libby, do you want me to read these off, or should?
You know what, since you're looking at them right now, that's great. Why don't you go ahead, and I don't need to be the intermediary. Go ahead.
That sounds great. Dean Germano, this last point of shifting work to the PCP is exactly the pushback I get from my medical staff about e-consults. We heard it time and time again. Absolutely. Everybody's busy, right? And so to the extent that you're shifting work onto somebody and not accounting for that in the workday, I think that's something that we're going to continue to hear about as administrators. Paul Gibbon, and I apologize if I'm not pronouncing names correctly here. Paul Gibbon.
Oh, that's okay. And you know what? I should help you, Jess, and say, I know everyone, so thank you, Dean Germano. Really appreciate that. And Paul Gibbony, go ahead. Joe, go ahead.
We've also had PCPs raise the same concerns in our system, but have prioritized the patient-centeredness of treating the patient in the most optimal location, which is usually the patient-centered medical home. We've tried to empower the PCMH team to help with this expanded work. And I think, as clinicians, we all sort of reflexively and probably appropriately go back to say what's right for the patient. And when I have a patient who has complex needs, and travel is really hard, and travel is really hard, particularly if you live remotely, e-consults are great. The flip side of that equation is that burnout turnover among particular primary care workforce is really remarkable. And that is, outside of the context of 2020 and 2021 and what the pandemic has done to all of us. And so, I think we do have to be mindful about what additional work we're asking people to do and how we're accounting for that.
So Joe, I want to jump in here because there are a few similar questions.
Okay.
So Dr. Batra from IHP asks a question, are e-consults required to specialty referral or prior to a specialty referral in the VA system? There was a similar question around just, so is a PCP trained to use e-consult as the first step to a referral, or how do you approach that with your primary care providers? Do you ask them to use it first?
Yeah, that's great. E-consults are not necessarily required. And I should take a step back and say there's a tremendous amount of flexibility at the local level, within the medical center level, to decide how they're going to roll these things out and triage them. And then as they get delegated to the specific specialties, specialties also have a tremendous amount of leeway in terms of how they operationalize these things. And so if I go and I want to consult urology and say I have somebody with hematuria and they need a cancer evaluation, that might get triaged automatically to an e-consult mechanism, whether or not I want it to be or not. They might require testing before that consult actually gets put in. It really happens to fall on sort of the local specialties and local medical centers to decide on how that works out. And then in terms of training, that is also left up basically to the local facilities to decide how they're going to train their clinicians to manage these. And that's from my perspective, as a little bit of a black box to say what that actual training looks like.
Great. I want to step in and combine a couple more questions too. I think what I really appreciate about your data here is that you come out with some really great findings around cost, but you're also very candid around some of the drawbacks, right? I mean, we have challenges. So a couple of questions and comments on the challenges here are, maybe you can comment on the feedback process between PCP and specialists. Looks like through your interviews, there are definitely recommendations or some observations on what challenges are to PCPs and specialists, and some of them are the same, like maybe some lack of clarity around roles, but that doesn't say that that's relevant necessarily to the electronic communication between the PCP and the specialist. But maybe you can speak to, Joe, what has been done to sort of clarify what primary care roles are, what specialty care roles are.
Yeah, that's great. So you mentioned being candid with my findings, and that's my goal. The number of times we've fallen on our faces because we've relied on observational data outside of interventional data. The numbers are piling up, and so I do think that, as I said in my very first slide, I consider this to be a really preliminary look at economic analysis and return on investment for e-consults. A lot more work has to be done before we can confidently say any of this holds up. In terms of what the specialists and PCPs fed back to us, nothing has been done so far. Let me take another step back. I don't know what's done so far. A lot of this falls on the local facilities and local specialties themselves to manage how these roles happen and the training that comes out. And so it's unclear to me what could be happening at the regional or facility level that we just don't know about. In terms of role clarification, that's a little bit about what our toolkit gets at. And it's not that we've clarified roles in our toolkit or made a recommendation of what roles should look like. Because as we know, it's not that simple. The way that specialties interact on the ground is not something that's universal. And so I can't say, here's how a primary care doctor should manage e-consults when they're working with oncology, and here's how they should do it with pain medicine. What we recommend in our toolkit is that this is really sort of a stakeholder engagement process, and that if you're rethinking about how e-consults are going, you want to get an e-consult program off the ground, well, it's time to bring everybody together and say, here are the expectations and here are the role responsibilities. And 6 months from now, take notes, because I think we should come back to this table and rethink the problems that came up, because this is new work. We just don't know what the appropriate formula is.
Thank you, Joe. And it sounds like a lot of the learnings that you have found are woven into your toolkit. So there's a question here around, are the learnings from about the suitability of e-consults for different specialties or acuity of care needs, are those woven into the toolkit?
We hint at this, but we don't comment on the suitability because we just don't know yet. What we know is that, and this just makes sense, right? But what we know is time after time, if you talk to providers on both sides of the equation, they say, there are certain questions and there are certain patients who are great for this. There are certain questions that are terrible for this, and there are certain patients that are terrible for this. A simple medication recommendation. How do I interpret this test? Something like iron deficiency anemia, some of these things I think nothing is straightforward, but can be done relatively more efficiently than other clinical questions. But again, there's been no work on this, at least to my knowledge, of really who's best suited for e-consult mechanisms. So we don't have that information, unfortunately.
Yeah, I mean, I think a lot of studies are focused on different populations, but this set of the numbers that you have or that you're able to incorporate into the study are very impressive. This is a much bigger study than we've seen typically. So another related question, if you're going to do a pilot, here are the areas that return the best cost savings, least stress on PCP, best health results that may be difficult to generalize, but I'm not sure if you can comment on that. Is there enough data on that to say, this was how I would do a pilot? Is that what your toolkit refers to?
I'm sorry, I'm not sure I followed that question. Can we do that one more time?
Sure. I'm looking at Helen's question. So do we have enough detail to say, if you're going to do a pilot, here are the areas that return best cost savings, least stress on PCP, or best health results?
No, I don't think so. I don't I don't know of any data looking at comparisons of outcomes to say, here's where the health results matter. This is one of the few studies that has looked at costs. And you could go off of it to say, here's where we might save the most costs, but there's two problems. One is, how do VA cost data generalize to private healthcare systems? There are simply just different cost structures there. That's not my area of expertise, but I know there are big differences there. And the second is that would be a preliminary attempt. I mean, I would not confidently say that this is where you would invest to save money without looking at these costs over the longer term. I think this is just sort of the preliminary look at that.
Thank you so much, Joe. And I want to note that Lisa Arfons, Dr. Arfons is on also. She's one of our clinical advisors. And Lisa, you are welcome to unmute yourself and share any comments that you have.
I mean, really no additional comments other than just to give a perspective. I'm a hematologist, and I have been doing e-consults at the Cleveland VA pretty much consistently as the only hematology e-consult provider for about 9 years. So I have a pretty long history and relationship, and just completely echo what Joe says about engaging stakeholders. We did do a study demonstrating cost savings for our veterans, both from Benny travel pay and estimated mileage, gas dollars that sometimes we do pay back as well for veterans, and also showed that e-consults in hematology were very safe, meaning that only 2% of veterans that had e-consults actually needed follow-up. So when we were able to combine that then obviously with understanding what some of the PCP concerns were, it made it, number one, the primary care providers heard, they felt heard. I did change my practice to accommodate. And then I think when they understood the benefits to the veterans, I think that they were more willing to incorporate it into their practice. To some of the other points, you know, we are able, as Joe did say, can move consults fluidly. So where we usually run into trouble is if providers refer them for face-to-face care and it results in an e-consult. That was not something they're expecting. I think when a provider refers, starting with an e-consult, they have that expectation that we may give basic recommendations for them to implement. Over time, I have seen a bit of an evolution because I've been doing this for so long in some of our providers' practice patterns where they do use e-consults more. And then finally, I do try to be very attentive to too much back and forth. And if I find that I am making recommendations on the same veteran, even more than twice, to be honest, I bring them to clinic. I think it's much less burdensome for the primary care provider. And, you know, ultimately we have to learn, okay, something is telling us, you know, it's probably time to see that veteran face to face or offer them a video visit, et cetera. So I rarely do prolonged care with e-consults. And I think that I hope all of that collectively has helped with stakeholder engagement.
Thank you so much, Lisa.
So thank you.
Joe. And I did want to open up for any more questions that are coming in through chat. Joe, if we're unable to get to them all, I'll make sure to share them with you by email and get back to our respondents. And I did want to open up to a few other reactions. So we have Julia Murphy, who has been involved in our work group for a while now, Director of Dissemination from Peterson Center on Healthcare. Julia, did you have any thoughts on what you've heard so far?
Hi, Libby, and thanks for the presentation. It's really great to see your work. Very, very impressive. You know, at the Peterson Center on Healthcare, we're doing an implementation effort with a commercial payer, looking at a comparative effectiveness study in a commercial population. And Pragya Singh from Mathematica, who's our evaluator, is also on and has been asking questions in the chat. You know, I think for us, we're just really curious about how we can learn from your study and build on it in terms of both the methodology that we use and also continuing to create a broader body of evidence around e-consult adoption. So I don't know if you have any comments on that. And also I'd invite Pragya to come in too, if she has any specific questions that she'd like to add.
Other than what I said, I think the one thing that really hangs heavy on me right now is not being able to adjust for differences in consult reason. You can adjust for patient complexity, prior month costs, but if it's simply a new condition that is more costly, that's not something you can account for in models like this. And so I think when making sort of a finer grain analytic approach where you're actually looking at consult reasons, I think is going to be probably the most informative approach in terms of how much money can actually be saved with an e-consult mechanism. That's my only thoughts for next steps.
That's very helpful. Thank you.
Pragya, did you have any comments?
I think I asked all of them in the chat, but I was curious if you at all like explored what was leading to the cost savings, like what utilization patterns were driving those, which particular, is it like visits avoided, or is it just less ED visits or things like that?
Yeah, we don't have those data. So we have the lump costs, and we have not actually gone to actually look at the different utilization patterns after the consult. And I guess if I were to add something else, that's a great point. That would be the other thing to start looking at, would be differences in utilization. There is a question asked, and I've seen it in my personal practice, that an e-consult in some cases just delaying the inevitable face-to-face visit. Not necessarily a bad thing, but it's something that's kind of on our learning curve. And so looking at utilization is a big deal, I think, and we just haven't done that. There's been one study out there that looked at costs after cardiology e-consultation and had broken down their costs into finer buckets than we had. And I believe that the cost savings associated with cardiology e-consult in that study fell into this category of residual claims, which I was never quite sure what that was. I think that's an important line of work that we haven't done yet.
Well, thank you, Joe, Julia, and Pragya for sharing your thoughts. Lisa too. And we have so many questions coming in. Joe, we'll make sure to connect with you offline to close the loop on any that we missed here. We really appreciate your time today and the informative study that you shared. So thanks again.
Thank you, everyone. Have a good day.
You too. With this, I'm going to hand over to Dr. Brunner from Monarch Healthcare and Susie Goldenkrantz with Rubicon MD. Without further ado, Susie, would you like to do a quick introduction?
Yes, hello everyone. I'm excited to present a little bit and introduce one of our partners, Dr. Brunner, who is at Monarch Healthcare in Orange County, California. A little bit about Rubicon MD. I'm sure many of you are familiar with us, but we work across over 160 specialties and subspecialties and have rolled out e-consults for about a couple of years now with Monarch Healthcare. So I'm going to let Dr. Brunner run through some of the statistics from his amazing leadership in Southern California. But you can see some of the statistics from our e-consult work, and this is just within Monarch, over 1,500 e-consults since we began this project. And I did a little back of the envelope math in conjunction with our partners internally, but this comes to about $1 million in cost savings for the Monarch family. So significant impact as it comes to the work that we've done. And Dr. Brunner will let you take it away a little bit on how you have worked with your clinical partners, some of the impact, and then we've also prepared a case just to give a little bit more information. And of course, please, I'll keep an eye on the chat as questions come in. So we'll make sure we get to a couple of them before we close out for the day.
Hi, I'm Scott Bruner. I'm a family physician, practiced for 32 years in the Orange County area in Southern California, and recently have taken on a consultant role with the Monarch IPA, Independent Practitioner Association. The initial push for e-consults came from medical director of Monarch, who was looking at surveys for physician satisfaction, patient satisfaction, and there were some of the more frustrating things for the primary care doctors. As I was a family physician, I felt some of these frustrations myself. One of the biggest was access to specialty care in certain specialties. In my area of Orange County, it was neurology, rheumatology, and somewhat dermatology also. The motivation initially was to increase physician satisfaction and in addition to increase patient satisfaction. So Dr. Borner reached out to Rubicon and developed basically a pilot program. She chose a number of primary care offices in the Monarch environment, and across a wide variety of practice arrangements, solo practitioners, group practices, and looked at some of their referral patterns and had some very specific reasons to offer the pilot to these different offices. I was involved as the physician champion in helping to train, explain, and answer questions, and roll out this as a pilot project to see would physicians, would primary care doctors take this on? Would it be something of value? Would this be something that Monarch would sign on to for a longer term commitment? My role really was in the clinical realm, the business aspect of this, the cost savings, the statistical analysis has been done more with the Rubicon team and the medical directors. The numbers here speak for themselves. I can tell you that initially when this was rolled out, it was presented to, as I said, a wide variety of independent practices throughout Southern California. Interestingly, the uptake was not exactly what we expected. There were some champions who just took to this and submitted e-consult after e-consult. Some never really glommed onto it. And this was with follow-up from me and the team, and this was pre-COVID also. So we were able to visit offices, provide lunches and lots of incentives and answer all sorts of questions and present this to many different types of practice arrangements. As the year wore on, we actually did run into COVID, and our training was limited to virtual training. And we thought this was going to be a significant confounder in the pilot program as to how this would be taken up by the primary care doctors. And so for some, it created a perception of more work. As Dr. Simonetti showed, there were some primary care doctors that felt that this put more onto their plate. Others found exactly what we had hoped they would find, that this improved provider satisfaction and patient satisfaction, especially as some offices, some of the specialty offices closed down, some of the primary care offices closed down, and more visits went to virtual visits. The ability to offer an e-consultation saved patients their specialty copay, that saved them the visits. It sometimes saved an emergency room visit. And this was presented to a certain extent as an ability, well, as an opportunity for primary care doctors to have a little bit more control, a little bit more quarterback of the team sort of approach. E-consults would come in, and these were not specifically part of the medical record. And so an e-consult could be accepted and placed in the medical record just as we call them, curbside consultations. As doctors sit in hospitals making rounds, they're asking questions in the hallway, at the nurse's station, and that sort of thing. And so a primary care doctor gets some guidance without necessarily attributing the guidance to a specialist. And that is appropriate in many, many cases, since more and more primary care providers, family physicians, general internists, general pediatricians are residency trained and have the training to carry out these recommendations from the consultants. So the consultations come in from Rubicon anonymously. They are sent out to multiple medical centers throughout the country, academic medical centers, but the consults come back with very, very practical advice. And so physicians are able to, pick and choose what they like. The platform allows follow-up questions. The platform allows rejection of the consultation and submission for a second opinion without any additional typing and copying of imaging and labs and that sort of thing. So very, very provider friendly. Towards the end of the 1-year pilot period, we chose several of the higher utilizers amongst the IPA, but we found that we had a better uptake amongst a group, the largest group that actually is affiliated with Monarch, part of the same family. Monarch is an Optum Care affiliate with it's a little bit complicated, but Optum is a division of United Health Group, and Optum Care has within it Optum Care Medical Group. These are a wide variety of primary care offices that were acquired and are unified on a common medical record, but they come from very different places. Anyway, what we found was that because of the more unified, organized reinforcement of e-consults, not punishing, but giving the opportunity and the explanation, and some of the meetings that the Optum Care physicians went to allowed for these physicians to really expand their use of e-consults. So I'm going to stop there for just a second. What I've been asked to do is, as a clinician, to present, where my understanding is the audience here contains not only clinicians, but also policymakers. And so what is an e-consult? How do our primary care doctors use these? One example is the one that I want to present. Susie, if you want to add anything before I start this, please feel free to jump in.
No, I think that was a great overview. And I think the results really speak for themselves. I think the pilot took off. We saw utilization across many different specialties and subspecialties across the organization. And that was before and after sort of the COVID crisis began. So really impressed with how the clinicians took it up. It took a lot of work from you, from the medical directors, from our engagement team, but there's been just some really fantastic results. And I think when we look at those 60% avoided service rates, when we look at the under 2-hour turnaround time, the results really speak for themselves. And I think that has led to even more clinician adoption. So we've picked one case from Monarch to share here, especially as it relates to cost savings, given the theme of the day. But Dr. Brunner will let you quickly run through this. And then if there's any other questions that folks have, Libby, if any were sent to you, we can quickly run through those at the end.
Right. Since this is handed out, you have the details. I'm going to just do a brief overview of the next consult of this e-consult. If you can go to the next slide, please. When an e-consult, next slide, please.
Libby, maybe jump 2 ahead. There should be an end.
I'm going to start describing it as I'm pretty sure it was in the deck, but
you know what, Susie, I'm sorry, I may be missing one. So my apologies. If you wouldn't mind speaking to it.
I certainly can. This is There was a question here that the overview is in front of you, a 63-year-old female who had lung cancer screening a year prior to her e-consultation, recently had a CT scan for generalized abdominal pain 1 month prior. Both scans showed incidental adrenal masses. This is a very common problem in medicine that when these masses are found, the big question is, does it mean anything? Her plan, the primary care doctor's plan, was a dedicated adrenal CT scan in 6 months. Her request was asking to provide guidelines for evaluations of incidental adrenal masses. The consultant's response discussed the standard of care for evaluation of adrenal masses, and then went into details characterizing the risk of a pheochromocytoma, Cushing's disease, and the chance, the 10% chance that some of these incidental omas would turn into something more significant. He or she recommended lab testing with specific recommendations for how to do this lab testing. It's a bit complicated. Patients need to be off of certain medications and be given medications before the blood testing. The specialist gave guidelines for interpreting the results and offered the suggestion that additional testing needs to be done for hypertensive patients. And here we are. For your reading pleasure, the details are right here. But basically, the consultant said that the need for a CT scan is controversial. That's well understood by most primary care physicians, but the consultant then gave references without going into a real high-level academic discussion of this. The practical information that the primary care doctor needed was that a CT scan is really not needed, but the consultant suggested contacting the radiologist to make sure that there was no, that the appearance of these lesions was benign. He or she also offered the opportunity to follow up with her, just in case that some of these services were not available in the clinic, and obviously gave the option to consult in person, face-to-face with an endocrinologist. From my standpoint, this offers clearly a practical guideline for the primary care doctor to manage this problem. The literature is quoted and offers to be of assistance in the future, answering questions, follow-up questions, weeks or months later as the need arises.
Dr. Brunner, just quick question. Which EHR do your primary care providers use?
Very good question, because that's one of the unifying factors that made it a little bit easier, somewhat. Well, it definitely eased the way we use NextGen. It is not, but I'll say this, the Rubicon is not embedded. It is not integrated into NextGen. What the IT team was able to do was create links, an internet web-based link to access Rubicon with one click.
Thank you, Dr. Brunner and Susie. We had such a great view into your experience, and the case is included in the deck. I'm sorry I switched the order of the slides by accident. Everybody has this in their email. I really appreciate your time today.